Okay. So for this particular question, the things which are important are related to 4-year-old child. The second thing is Down syndrome, and the third thing is adenotonsillectomy. So 4 years child, or I will tell the for these points for pediatric, elderly, pregnant. Okay, like pediatric means neonate, or a child. If you can just keep your mic mute, because it's a distraction for me. So in all, like, because the same scenario in which there will be something else as a disease and something else as a patient population. So try to think in 3 steps, that what is the change in that thing, and what is the effect on your anesthesia management, and how you manage. Okay. So if you just, for example, we if we just think, to start with, if we just consider that these pediatric patient, they have challenges with the airway. Okay, so airway challenges, whatever the result is, that not only they have different anatomy, and they have the word which you were telling was related to physiology. So they have different altered physiology and altered anatomy. So the result is that not only that you can face more time intubation, the patient will desaturate early. So a combination of all the things, the changes, the anterior larynx and big large tongue and big head, and anterior larynx and small trachea or whatever. So the ultimately result is that you can have a delay in the intubation, and physiologically, because of reduced FRC and increased oxygen consumption. Okay, and all the reasons, the patient will desaturate. So you have less time, and you have more challenges. So this is how you will chalk them out, that related to airway, these patients have challenging airway with, because of this points. So this patient can desaturate early. So what you have to do, you have to anticipate always, that the word is anticipation, that you will always anticipate difficult airway. So this is the answer, that you are anticipating difficult airway. You just need to optimize the position of the head. You need to have the straight blade. Okay, so there are certain things which you can do, pre-oxygenation and things like that. So for all these points, you can make your prepared answer. So the lesson number one for today you will be, for that you prepare an answer in which you can tell in 30 seconds to 1 minute maximum, related to that population group, whether it is peds, whether it is neonate, whether it is elderly, whether it is pregnant, where the same in the same, I will make smoker, I will add opioid addict, I will add steroid dependent, or steroid receiving, the patient who is steroid receiving steroids, and also diabetes and hypertension, because they are so common that it is better that you prepare your answer before. Pediatric, neonate, elderly, pregnant, smoker, yes, sorry, obese, because there will be no exam which will be finished without having a question related to an obese patient, without a patient, pregnant patient, pediatric patient, smoker, diabetes, hypertension. Okay. So your first part of answer will be related to that one. And as I mentioned, I will tell again that what is the change, what is the effect, and how to manage. Okay. So now you will think that how I will put this thing in here, or diabetes or hypertension. So in table Viva, when they are asking you, they are not asking you to tell the whole of diabetes mellitus or whole of hypertension. In a table Viva scenario, in a short case scenario, in a like even in a discussion, this is not only for your Viva. This is just to make you a good anesthetist as well. that if you think that you have a diabetic patient, so you can have a very good word for that, that there
मेरे
are.
भी आने के लिए चार्ज होने दो.
Can you mute your mic, please? That you have a like microvascular and macrovascular complications related to diabetes mellitus or hypertension. Both of them have almost similar problems in a different way. Okay. And both of them are interlinked. So, what will be the microvascular problem? Microvascular problem will be in the kidneys and in the eyes. Okay. And the third will be in the autonomic nervous system. Okay. So, these are microvascular problems. And the macrovascular problems will be in the form of either in the brain, either either in the heart, okay, or in the peripheral vasculature. So now you can make your answer that because of microvascular and macrovascular complications of diabetes, you can have retinopathy, nephropathy, and autonomic neuropathy, and macrovascular complication in the form of in the brain, heart, and peripheral vascular disease. So brain macrovascular complication will be either CVA or TIA. So you just have to speak out in a way that I will say, though it is not a good idea to cram the answers, but for diabetes and hypertension and pediatric and elderly and pregnant, I would recommend you to just cram an answer in which in a compact words you cover all the things. Okay, so whatever the case is, even it is diabetes or hypertension, the end result is ultimately in the form of CVA or TIA. Either it is old or new, or it is active or resolved, whatever. So so you will be using the word. So we will be evaluating the patient on the basis of history, examination, and relevant investigation to rule out microvascular and macrovascular complications in the form of either CVA, TIA, ischemic heart disease, MI, heart failure. This will be in the heart. Okay, and in the peripheral vasculature, it will be in the form of intermittent claudication leading to ischemia and even gangrene. Okay, same answer, like I will repeat the, because this is so important, so I want you to learn this so that you don't miss this question, that you have you the same scenario like that we are discussing at the moment, that 4-year-old child for Down syndrome. So make it, change it with 50-year-old man with diabetes and hypertension, and change the adenotonsillectomy with cholecystectomy. Okay, so the answer will become like that, as I'm telling you, that there are microvascular and macrovascular complications in the form of this. So we will be evaluating the patient. You, because the you whenever I ask this question, the answer which is starting is, sir, we will take history, sir, we will do examination, sir, we will do this, we will do that. This is not an answer in table Viva. You have, again I repeat, you have these three things, and you have maximum of 5 minutes in total for one case. And 1 minute, roughly you can say 30 seconds to 1 minute they will take in asking the questions. So practically you have only 4 minutes. So just imagine, in 4 minutes, what do you want to answer? You want to answer in a bizarre fashion without any clue, or you want to be pinpointed? If they want to ask you further details, they can ask you, like you can say any relevant cardiac symptomatology, any history of failure, any sign symptoms related to failure, and any history of ischemia, any examination finding and resulting in the failure. So no, you know everything, but you don't know what to speak out. So what happens, that people go indulge in the deep depth, and they are not asking this question, and you are just went inside, and they are just dragging you out. And in the way in between, if you answer something wrong, then you are in a vicious cycle and they fail you. So if you start your answer in a way, as I'm telling you, I can guarantee you, you will not have any problem. So And you can make this answer for all the diseases, by the way. You can make the same answer for myasthenia gravis. You can make the same answer for anemia. You can make same answer for liver failure. You can make same answer for renal failure. This is what you have to extract. What you say, that you just have to make a wine out of a lot of fruit, or you have to make a compact thing. Okay, so for that thing, you just have to
सर
think.
डायबिटीज के अलावा किसी और, सॉरी सर आपको वो कर रही हूँ, डायबिटीज के अलावा किसी और पे जरा एग्जांपल दे देना सो वी कैन बी क्लियर लाइक व्हाट वुड बी द लीडिंग क्वेश्चन एंड हाउ शुड इट बी आंसर्ड.
No, leading, listen, remember one thing. Let me clear to you what the strategy which I'm telling you, it is for table Viva at the moment. Though this is the same strategy is there for long case. Okay. The same strategy is there for the long case, but actually in long case, you are asking the questions. And in table Viva, you are just telling that we will be evaluating on the basis of history examination and relevant investigation. So your question is that how we can speak out for, let's take myasthenia gravis, for instance. You can make the answer that myasthenia gravis is a neuromuscular disease. So the relevant answer is that there is post-synaptic destruction of acetylcholine receptors, so resulting in muscle weakness. So the basic problem here is involvement of bulbar muscles, involvement of respiratory muscles. These are the two main culprit in the pathology of myasthenia gravis. The third, the other thing which is related is the medications. Okay, and the other thing is related to the coexistence of autonomic, sorry, this autoimmune diseases. Okay,
रेस्पिरेटरी डिजीज.
no, 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 coexisting autoimmune disease. Okay, there is association of other autoimmune disease. You are right. Again, this word which you have poked, I will tell you, this is the reason that all of you have in your mind that you have to reproduce the word of books, because there is a word, there are more chances of post-operative ventilation if you have a coexisting respiratory disease. So you are thinking that I'm telling this thing. Unfortunately, at the moment, I'm not telling this thing because I've already told this as a respiratory muscle involvement. So bulbar muscle involvement. So what sentence you can make like that, that there is bulbar weakness, so the patient will be at risk of aspiration. Respiratory muscle weakness. So not only that, already there may be respiratory weakness, there will be more chances of post-operative ventilation, especially now the word which you were saying, especially if there is some coexisting respiratory disease. Okay, because in the book there are points written that periodistic mean dose more than etc., disease duration more than 6 years, and coexisting respiratory disease, and vital capacity less than that. Okay, so these are the words, but I tell you something. If you want to understand, you have to know. So this is this is roughly you can make like that, because there will be immunosuppressants. So as I mentioned in the common list, steroid. So again, steroid will come here. Steroid will come in. So you should make a list in patients where patients are taking steroids. So all autoimmune disease, you can bring steroids. Okay, all autoimmune COPD, you can bring steroids. So there are so many indications for steroids. So that's why I asked you to have this list of steroids as a common thing. So now you will say that there are bulbar involvement, as I told you. The other thing will be respiratory vessel involvement and coexisting autoimmune disease, and the medications having multisystemic effects. So all the immunosuppressants patient will be taking. Where word immunosuppressants come, you can broadly say that immunosuppressants, different immunosuppressants and different degree have effect on bone marrow, have effect on liver, have effect on renal. So you can expand your answer. And actually, whatever is there in the key, they will ask you. So this will be creating a good impression. So my suggestion will be that instead, because what if they will ask what is myasthenia gravis, you are trying to find the definition which is written in the this your terrible crap Morgan. Okay. So if you will be trying to reproduce this, you can. I'm not saying that it is written wrong, but that is not what actually is required. Okay. So I hope I answer your question. So similarly, I ask this question to all of people with whom I'm talking. Sickle cell disease. So can anyone answer what is sickle cell disease? Yes, please. What is sickle cell disease? So the answer which we get is starting from valine to glutamate. This is the worst answer you have. You this the people the whatever definition usually people tell, the word anemia never comes. So it's an anemia because of a hemoglobinopathy. Okay, because of this bloody change, valine versus glutamate. But people only remember this, and they forget that this is actually is an anemia, and it's an hemoglobinopathy. So resulting in a fragile RBC. So the fragile RBC will not be able to tolerate the twists and turns. So either it will have a vaso-occlusive crisis, a plastic crisis, sequestrational crisis, or hemolytic crisis. Okay, so either of them will occur. Okay, so whatever the result will be in the form of severe pain is one of them. The other thing is ischemic crisis, infarcts. Okay, ischemic crisis everywhere, whether it is in the abdomen, in the form of priapism, and in the cholelithitis, then in the form of peripheral ischemia, CVA even, and pain. And whenever the word pain comes, then opioids will enter. So opioid dependence will come. Okay. So these patients are terribly opioid dependent at times. In Pakistan, actually, we never see. And when I came to Saudi Arabia for the first time, I came to know what the hell this disease is, because it's a terrible disease. Okay. So this is what you have to answer in sickle cell disease, and resulting in anemia. So anemia, you can say that what is anemia? Anemia is the decreased oxygen carrying capacity, resulting in, like, a patient is not able to handle the load, the metabolic requirement. So there is cardiac response, and there is the terminology of either compensated anemia or decompensated anemia. Okay, and that is important for anemia, sorry, for anesthetists, because all anesthesia, whatever we are doing, is affecting the heart. Okay. So if the heart is already under compensation or decompensation, the patient will not be able to tolerate the circulation. The cardiac output will not be able to maintain. This is one thing. The another thing is that if the surgery starts and there is further bleeding, so the oxygen carrying capacity, because it is dependent either on the dissolved oxygen, which is a very minor one, but mainly the hemoglobin. The hemoglobin is the vehicle on which the oxygen is traveling throughout the body. So if you don't have hemoglobin, how oxygen will be traveled? Okay. So that's the important significance. So because if hemoglobin is not there, the other thing is, of course, oxygen saturation, but dissolved oxygen is minor. So that's why anemia is important for anesthetists, because then what will happen? The result will be tachycardia, increase heart rate. So increase heart rate will decrease oxygen supply to heart. Okay, so this will become a vicious cycle. So if someone asks you any thing related to anemia, this is the answer which you, if you are able to understand the like that pathophysiology, you will not miss the answer. Okay. So I will tell you, make, if you go haphazardly, then you cannot do anything. But if you just go with sense, you can make, believe me, you can make answers for all the diseases like that. But away from the books. But if you, because if you will try that, you will be worshipping the books. Unfortunately, the in the exam, one of the reasons, yes, people who claim that we read Morgan and we pass, they are much more intelligent than the people who fail. So I was not intelligent, that I was not able to, I used to fail, alhamdulillah, a lot when I used to read that bloody book. So that's why I want all of my friends to be away from that bloody source, because that's a curse from maybe some biggest anesthetist or oldest anesthetist in the world who did some crime, and the curse was given in the form of Morgan, to, because you are a criminal, so read Morgan. So if you I think you should all the ladies should give a Morgan to your mother-in-laws. Anyways, sorry to be distracted. Okay. So I hope I have told you. So because I in these few minutes I cannot tell you all the details, but I have given you up till now in these minutes. But I have told you that you make an answer for pediatric, elderly, obese patient, pregnant patient. Answer like this: the pregnant patient, reduce FRC, high oxygen consumption, high oxygen requirement, chances of desaturation, on top of that, chances of aspiration, on top of that, possible difficult intubation and difficult mask ventilation. So the answer is, you have to do the how to tackle it. You have to do the ramp position. You have to elevate the head side, elevate the tragus to the level of angle of Louis, this sternomental angle. You have to pre-oxygenate. You have to give acid prophylaxis. You have to do rapid sequence or modified rapid sequence induction, and you have, that's it. So like, you can make your answer compact. You can this will all come with the practice. So few words about the surgery, because any patient will, in the scenario based question, there will be one surgery. So the things which will be related to the surgery will be that all the surgery, you have to think whether it is emergent oblique urgent, or it is elective oblique planned. There is a small difference between planned and elective, and emergent and urgent, but actually they are used together, and they are used together. So actually, real emergent surgery is, for example, uh, like a major vascular firearm, for example. You cannot delay it at all, because patient will die if you don't open and don't control the bleeding or whatever. Emergent cesarean section with fetal distress. This is real emergency. Okay. An incarcerated hernia which can go to gangrene if you don't open it immediately. So these are examples of emergent surgery. The next are urgent surgeries like appendix, like laparotomy for intestinal obstruction, things like that. Okay. So you can go one by one, and you should make a list of common surgeries. Maybe I will show you whatever I have done for this topic, so it will help you. So similarly, difference between elective and planned, like lap chole, we use it as elective, but it's not an elective surgery. It's a planned surgery. You cannot delay it forever. And elective surgery theoretically are joint replacement, cosmetic surgeries. These are, in true sense, are elective surgery. This is one category. The other category is with reference to their risk. Okay, risk involved. So high risk surgeries are, for example, liver transplant. This is a high risk surgery. Aortic surgery, cardiac surgeries. Okay. Then, like for example, open prostatectomy is a high risk surgery. So you will find a list of surgical risk stratification with reference to high risk surgery, intermediate risk surgery, and low risk surgery. You can have a look. So you should be knowing the surgery which they are asking. Either it is high risk surgery, intermediate risk surgery, or low risk surgery. Because if your answer is not related to this thing, maybe you will like it will be easier for you to answer if you know it. Then one thing is risk, and other thing is bleeding risk. There are certain surgery which are not very high risk, but there are more risk of bleeding. Example is Adenotonsillectomy. Adenotonsillectomy is not a high risk surgery, but it is a high risk for bleeding. There are chances of postoperative bleeding. Okay. And another thing is that the bleeding will be hidden. Maybe you are not able to identify that there is bleeding if the patient is swallowing. So this is a small point, that there is one urgency, risk, and bleeding. Then any critical step. So, so you should be thinking, whatever surgery they are asking you, you should think, is there any critical step in that surgery? Like giving you an example, that for example, if they are doing laparoscopic surgery, so the trocar insertion is a critical step, number one. Number two, when they start pneumoperitoneum is a critical step, because trocar insertion can cause vasovagal. Trocar insertion can rupture a viscera, rupture a vessel. Then pneumoperitoneum can cause actually, it can cause carbon dioxide embolism if it enters a major vessel. Okay. Or even if you are insufflating, there may be sudden vasovagal reflex, or there may be decreased cardiac output, or any patient who is at risk of the patient's cardiac reserve is not that much, and you need to keep it in a balanced way. This will be a critical step. And the third step will be CO2 absorption, gradual. Okay. So these three steps are the critical steps in that, like, because this will be absorbing and it is causing tachycardia, sympathetic stimulation, and it is a problem. Okay. So if you are thinking, so now think any surgery, like for example, tourniquet, placement of tourniquet and removal of tourniquet is a critical step. Making for example, in certain surgery like liver transplant or kidney transplant, they are reperfusing. This is a critical step. Aortic this aneurysm surgery, the clamping and unclamping is a critical step. So you can think about the surgeries, and maybe you will find one critical step, you will find two critical step, you will find no critical step, but at least look into the surgery, that is there any critical step. If there is not, you can make something, that in this surgery this is the point, in this surgery this is the point. So you should be knowing a little bit of it. Okay. Then another important thing is the extent of the surgery and the extent and level of incision. Okay. Because this is why it is important. Because if you don't know where is the incision, by the way, how can you give analgesia? How much is the extent of the surgery? How much, which dermatomes are involved? You cannot plan a regional anesthesia without it, because of if you don't know about it. Okay. I still remember a person who's mashallah now working as a specialist somewhere in the world. I asked him, and he did not he failed, and he was very unhappy. He was saying, I will leave FCPS because I don't know what they want to ask. And when I probed the Viva, he doesn't know what is the level required for urinary bladder surgery. He doesn't know that what sorry, not urinary bladder, TURP. So he doesn't know that TURP surgery required what level of anesthesia. He doesn't know about it. So how can, if for example, if the examiner picks you that he has no concept of a surgical what is, because surgery, you are conducting an anesthesia for a surgery. So if you don't know a critical step in a surgery, you can be, they can fail you. So you should be knowing for all surgeries critical steps which are related to anesthesia. I'm not talking about surgical steps. I'm talking about the steps or things, information which are important for the anesthetist. Okay. Then another important thing is positioning for any surgery. Try to have any surgery like lithotomy position, prone position, lateral position, Trendelenburg, reverse Trendelenburg. So any position. This is a very, you can say, bread and butter of surgery, that you should be knowing in which position they are doing the surgery. So even they will not ask you that you are doing a TURP. So they will expect you to tell that this patient is being done in lithotomy position. Okay. So you will be telling that the creation, and the in the positioning, one is the creation of the position and one is the reversal of the position. So you remember one thing, because if you don't evaluate the patient, and the patient is supposed to be in the lithotomy position, and you don't you don't ask this question to the patient, in practical, I'm of course this is not the table viva that they will ask you that, ask about the joint limitation, but you can say in the other word that in lithotomy position, the patient's joint limitation should be considered. Because if the patient does not have the joint mobility, you give the spinal, and now they try to did it, and there is a fracture. Okay, because the joint was restricted, and now even patient does not feel, and you manage to have a fracture. So that it's that much important. Okay, so there are certain things which you should be knowing about the surgery. Okay, I will just show you one document. So I share this document a number of times, but let's have a look at it again. This is not, I'm saying that this is the last way to target a Viva. But if you do like that, it will be very easy. Okay. It will be very easy for you to answer the question. Okay. Whether it is stable Viva, whether it's long case, whether it is anything. So related to disease, we discuss about the surgery. Let's finish this thing. Urgency, surgical risk, bleeding risk, patient position required, usual duration, level of incision required, level of anesthesia required, possible anesthesia option, possible analgesia options, potential concerns and complication, specific age group prone for that surgery. Okay. So you should be knowing that specific, there will be specific age group and specific equipment, location, staff, medications, logistics required. So because this will also cover NORA, non-operative anesthesia. Okay. This is not surgery, but you can put it in the same way that there will be specific requirements for that thing. There will be specific certain things which you will be like any patient having laser. So this is a equipment. This is a hazard. Okay, so you can radiation, X-ray. There are so many things which you can do. Any surgery in which you have limited access to the patient. This is the problem. Tube can be disconnected and everything. So these are the things which you should be thinking about the surgery. And this is for disease. Okay, so disease, main category, pathology, and mechanism of problems. So as I mentioned you before, that if you know the basic pathology, in the sense that you should know what is happening, so it will be easy for you to tell. Diagnosis of the disease. Diagnosis means like evaluation in the form of history, examination, and investigation. So it's sometimes, majority time, you are not doing the diagnosis as a primary physician, but they can ask you in long case. Because why? Because they are interested to you to know like how pheochromocytoma is diagnosed, how patient is diagnosed to have diabetes or hypertension. Now how like myasthenia gravis, the same answer will be how to differentiate between a cholinergic and a myasthenic crisis. Okay, and um, uh, uh, of course, this is a clinical diagnosis because the antibodies will not be identified in every patient. Okay, similarly, rheumatoid arthritis. So now this is a portion for each and every disease. Again, you should be knowing a little bit about the pathology. You, because there will be certain patients which can they bring in the long case. Okay, so rheumatoid arthritis patient, because now things have changed. Sometimes they are giving only the paper patient, but you have to be prepared for it. And actually, paper patient, don't be don't worry about it. It becomes rather more easy if you know what you are doing, then it will be very easy because long case it will not be covered in this session. I will tell in the next session, inshallah, we can discuss about the long case, but I'm giving you the basics are the same. The same thing you will be doing in long case, but here you will be asking the question to the patient. There you will tell that I will evaluate on the basis of history, examination, and relevant investigations, whatever is needed to see the severity. You should be knowing this word. I will be doing be evaluating the patient on the basis of history, examination, and relevant investigation to see now what is the reason to do this, to see the severity, to see the organs involved, to see the end organ damage, and what how it will affect anesthesia management and how much optimization I can get. Okay, the same thing I have written here. Evaluation on the basis of history, examination, and investigation. Risk assessment and stratification. risk assessment and stratification. And now think everything renal risk. If I ask you what is a renal risk, so for example, a diabetic patient is a renal risk. A patient having risk of bleeding is a renal risk. A patient having hypoperfusion, hypotensive anesthesia is a renal risk. Patient on NSAIDs, or if you give too much NSAIDs, or patient has a trauma patient who had rhabdomyolysis, or a patient who is receiving for any good reason contrast, these are all renal risk. So this is how you will see that, because you will not find these things in the books. I can bet on it. The only way to answer these questions is that you make your brain tuned, that what are the renal risk, and in every patient you are, whatever they are discussing with you, think, is there any renal risk, is there any pulmonary risk? Like for example, if similarly if I talk about pulmonary risk, smoking is a pulmonary risk. Okay, patient in which having a low albumin level is because the patient now will have leaky capillaries, so patient can have pulmonary edema, so it's a pulmonary risk. Similarly, upper abdominal surgery is a pulmonary risk. Okay, uh, severe pain, splinting is a pulmonary risk. So you can make chalk out in a very simple way. You don't need very fancy books to read to make this concept. This is very simple. Or use of opioids is a pulmonary risk. Patient can have respiratory depression. You are giving too much, for example, things which are decreasing the secretion. Like for example, you are using a lot of glycopyrrolate. It can dry. It can make the coughing difficult. So this can be a pulmonary risk. Okay, so you can think, use of all the things which are whatever you are doing, think out pulmonary risk, renal risk, cardiac risk, for example. So cardiac risk, because it's a long list. So risk of PONV. So what is the risk of PONV in which case patients? Any patient receiving opioids, female gender, okay, non-smoker, okay, then certain surgeries in which there will be more risk, like middle ear surgery, or and you can make a list. So I'm not telling you all the things. I'm trying to give you an idea. Try to have a PONV risk in each patient. Try to have acid this aspiration risk in every patient. Try to have like a risk of delirium. Like for example, if a patient, old age patient, extremes of ages, ENT surgery, this is a risk for post-operative delirium. Okay, so this is what they want you to tell, but they will not ask. You have to, if you make a list of these things, this is what is good anesthesia. Okay, so this is how you can tune your brain, practice, and rather than cramming the books at the moment, just try to find these answers. So as mentioned here, I have mentioned here at the end, looking the optimization or targeting reversible component of the disease, and estimating the cardiac risk, pulmonary risk, renal risk, aspiration risk, PONV risk, airway management. Any challenges with reference, if you see the patient has beard, you can easily say that this is a risk for mask ventilation. Okay, if you see a patient is edentulous, you can say this is a risk for mask ventilation. So and so on. Okay, any surgery in which, yes, this is what I missed. Now I will go to the anesthesia steps, and then we will finish our discussion for today. Every patient needs anesthesia standard 1 and standard 2 monitoring. All patients. Okay. So standard 1 and standard 2 monitoring is for everyone. So you will use this word, that you make a list that what other monitorings patient can have. So this is, for example, urine output. This is neuromonitoring for evoke potentials. This may be like monitoring for pressures. Okay, like for example, if you have a patient with COPD, in addition to standard, you will say, in addition to standard 1 and standard 2 monitoring, I will be doing the airway pressures monitoring. Okay, if you are used this myasthenia gravis, you will say, in addition to standard 1 and standard 2 monitoring, we will be doing neuromuscular monitoring. You are doing a surgery for facial, in which facial nerve is involved, you will say, in addition to standard 1 and standard 2 monitoring, we will be doing the facial nerve monitoring. And whenever the word nerve monitoring comes, you don't have to give muscle relaxant. Okay, you have to give anesthesia in a way that you are avoiding muscle relaxant. So there are so many ways for that thing. Like you can give tiva, you can knock down the patient with high class like this is another topic, that how you give it. But you will be giving you will not be giving muscle relaxant, and you will be doing not giving the medication which affect the evoke potentials. So a same answer will be there with reference to scoliosis surgery, with reference to neurosurgery, where they are doing the neuromonitoring. Okay. So this is example of specialized monitoring. And last but not the least, the cardiac monitoring. So any patient in which the swings of blood pressure are there, any patient with limited cardiac reserve, any patient in which you want to monitor the beat to beat blood pressure, you will say we will be doing invasive blood pressure monitoring. Okay. And any patient, if you are expecting too much blood loss, then even you can say arterial blood pressure, because you need to do the abgs, and abgs waveform can tell you about the volume status, about the systemic vascular resistance, about the contractility in an indirect way. So any patient like mitral stenosis, or any patient with failure, or even diabetic patient, you have to tell that because of diabetic autonomic neuropathy, there will be certain swing of blood pressure. So in this patient, if there is any doubt, we will have arterial blood pressure monitoring to have a better look on the hemodynamics. Okay. So pulmonary monitoring, pulse oximeter and end-tidal CO2 is everywhere. In addition to that, wherever is required, like there is BIS monitoring, there is neuromuscular monitoring, and few of the monitorings. You can think later on what different monitoring you can. And my suggestion will be, how many monitors will be there, 10 or 15? So make a list of the surgeries or the conditions or the diseases in which specific extra monitoring other than standard 1 and standard 2 monitoring is required. So very easily you can find it. Okay. So similarly, because all our medications are metabolized by liver and kidney, excreted by kidney. Okay. And all bone marrow will have this problem, that if bone marrow is suppressed, so not only there will be anemia, the patient will be at risk of infections, there may be coagulopathies. Okay. So you will be doing, you like this is you I shared this document a number of time. I am sure that some of you have seen it, some of you don't have, but I will suggest you to have a look, because this is what you know: pre-op, intra-op, post-op. This is a big distractor. I have written it, but believe me, because if with that in that list, you will never bring monitoring in the start of your discussion. Okay. And when you are starting the discussion, and 99% cases, you will forget that you have to tell about monitoring as well. Okay. So it's overstated word that you have to tell about the all these things. You don't need to say the word for everyone that there is no if there is nothing, you don't need to tell in this patient there is no cardiac risk factor, there is no pulmonary risk factor. No, you have to tell that in this patient there is a that if it is there, you don't need to tell everything, because in what we people do, that they have been told that you have to tell pre-op, intra-op, post-op. So they use this word, and they don't know what to tell after that, and then they are lost. Another confusion come, they are not able to tell, because they are confused what to tell in pre-op, what to tell in intra-op, what to tell in post-op. So I don't think so that this is a very effective way. Yes, you can tell whenever don't make it too much on your head. Wherever it is possible to tell in the form of pre-op, intra-op, post-op, you tell, it's good. But if it is not, don't overstretch yourself. Okay. So this is how you should be looking at all the diseases. And I would be very happy if you make your own paper for all common diseases like that. Okay. And one more thing which you should be knowing, that there is uh, what is called as good anesthesia. And I have made this word as my best friend. Okay. Because no anesthesia is away from it. So I will suggest to again, if you know this, it will be, so this is my best friend. normoxia, normocarbia, normotension, normovolemia. Sympathetic stimulation avoids sympathetic stimulation and stress response. Maintain not only myocardial oxygen demand supply ratio, but also you should add it here. I did not write it here, but I discussed many. It's written here. Maintain vital organs blood flow in especially brain and kidney. Okay, because brain can tolerate slightly low blood pressure than kidney. I repeat, the auto regulation for brain is 60 to 160. So up to 60 mean maybe brain will tolerate, but kidneys it is 80 to 180. So that's why there is, if there is hypoperfusion, hypotension, hypovolemia, the kidneys shut down much earlier than brain. And there will be no hypoxia, there will be no CVA, but there will be acute renal shutdown if you don't maintain the renal perfusion. That's why it's of utmost importance to take care of kidneys. Okay, so this is, so again, this the same answer you can use in your mitral stenosis or mitral regurgitation, that you have to maintain the sinus rhythm, you have to maintain the SVR, you have to maintain the preload and afterload. And I listen when I ask this question, they say, sir, we will do bradycardia. Sir, we, because it is tight and slow and tight, so we will cause bradycardia. And the answer is big no. If you do like that, your patient will die. So the answer is not like that. So you will say that I will not let the patient to have tachycardia, and I will try to have no low normal. You can use the word, or you can say I will not avoid I will not let the patient having tachycardia, because bradycardia, if the patient has severe bradycardia, even then patient circulation will not be maintained. So don't never use the word bradycardia, and never use the word I will increase the SVR. It's a death for the patient. If the patient already have reduced contractility, if the patient already have reserve or limited cardiac reserve, and you increase the SVR too much, will the heart will be able to contract? The answer is no. Okay. So again, you don't have to say that I will increase the SVR. When, because we listen that mitral stenosis, aortic stenosis, you don't let the SVR to go down. So we think that we have to increase the SVR. So actually, it's not like that. Because if the patient already have depressed cardiac function, and you just make SVR increase, the heart will fail, because heart is already under load. So this is just common mistakes which you can do. Okay. So any questions before we finish? Any questions, please? Okay. So inshallah, we will have some other session for the long case. Thank you very much. Bye bye.